So good morning, everybody. And again, welcome to the New England AUA's series of talks that we've started this year, and I think it's been heading out quite well. I want to introduce today Dr. Jessica Mandeville. My name is Kareem Hamway. We both work at Leahy Hospital and Medical Center. Jessica received her medical degree at Tufts University Medical Center, and then started her urologic training at Leahy, where she became well known as a dynamo and went on to an endourology and stone fellowship in Indiana with Dr. Lingeman. Jim Lingeman is a pioneer in HOLEP and stone disease, and she just subsequently came back and rejoined Leahy and heads our endourology and stone center. Today she'll be talking about surgical management of BPH, and I want to thank Jessica for coming on board and hanging out with us this morning. So go ahead.
Okay. Good morning, everyone. Please shoot me a message through Zoom if there's any trouble hearing me, or we'll probably do questions at the end because it probably will take close to the hour. But thank you for taking the time to listen to this talk. When I was asked to do this, I felt that, talking about HOLEP for an hour was probably not going to be terribly interesting to everyone. So I thought what we would do, given this is primarily for resident education, would be to review the new 2019 guidelines for surgical management of BPH and talk about all the emerging treatments for BPH. While I may not be an expert on all of them, we can at least go through the technology, some of the data coming out on these techniques, and go over a broad range of interventions that we use to treat BPH. So disclosures, I have no financial disclosures. My disclosure is that some of the procedures and techniques that we're going to talk about today are certainly not techniques that I am expert in, but certainly techniques that we should all know about. My practice has heavily skewed towards laser enucleation of the prostate for large glands, for redo glands, but I do some TURPs and TUIPs, and we've just recently started our delve into the world of aquablation, which has kind of been put on halt due to the COVID-19 pandemic, and we hope to get working on that again soon in the future. So the objectives today, let's first describe the appropriate definitions to discuss BPH and bladder outlet obstruction. Let's review the guidelines and the different techniques, and then maybe consider some novel use of BPH surgical interventions. So let's start with definitions. So first of all, BPH, benign prostatic hyperplasia, is a histologic diagnosis. It's a proliferation of glandular epithelial tissue, smooth muscle, and connective tissue in the transition zone. Benign prostatic enlargement is enlargement of the prostate due to BPH. BPH does not necessarily imply benign prostatic enlargement. And then finally, we have benign prostatic obstruction, which is bladder neck obstruction secondary to the benign prostatic enlargement. Now, you can have benign prostatic enlargement without having benign prostatic obstruction. We all know plenty of people with huge prostates who void just fine. So just because you have an enlarged prostate does not mean you're obstructed. And just for further confusion, benign prostatic obstruction is simply a form of bladder outlet obstruction. And as we all know, different things can cause bladder outlet obstruction, like a bladder neck contracture or urethral stricture. So then what are lower urinary tract symptoms? So it's a ubiquitous term to describe urinary symptoms in men and women. There are many causes of lower urinary tract symptoms, only one of which is benign prostatic enlargement or obstruction. Urinary tract symptoms related to BPE and BPO, according to the guidelines, are symptoms that have no other alternative cause, such as stricture or overactive bladder or neurogenic bladder, after a basic evaluation by a urologist or a practitioner. Benign prostatic enlargement and benign prostatic obstruction causes of LUTS are related to direct obstruction from the enlarged tissue, which is a static component, increased smooth muscle tone in the gland, which is the dynamic component, and overactivity and underactivity, which can be related to long-term obstruction. So now to get on to the surgical management of lower urinary tract symptoms attributed to benign prostatic hyperplasia. This is the AUA guideline recommendations from 2019. So the index patient is a 45-year-old male with no history suggesting non-BPH related causes of lower urinary tract symptoms after evaluation by a qualified clinician. So statement one, obtain a medical history. And what are we looking for in a medical history? What are their current symptoms, prior procedures, sexual history, and current meds? So prior procedures is particularly important because if they've had prior TURP or transurethral microwave therapy or even prior TURBTs, you have to consider the possibility of a stricture or even a neurogenic bladder. We want to look at their sexual history. This is important to patients. You need to assess if they currently are having good erectile function, what their ejaculatory function may be, if they would be terribly bothered by a change in ejaculatory function. And then finally, what meds are they taking? Are they on alpha blockers or 5-alpha reductase inhibitor and still having symptoms? Are they on 5-PDE inhibitors? Are they taking anticholinergics, antihistamines, which may be worsening their bladder function? Are they taking diuretics, which may contribute to urinary urgency frequency? The statement also includes utilizing the AUA symptom index to evaluate patients to assess the severity of symptoms related to benign prostatic hypertrophy. So you want to assess their symptom burden and their quality of life. And as we know, the AUA symptom score assesses incomplete emptying, frequency, intermittency, urgency, weak stream, straining to urinate, and nocturia with a score of 0 to 5. Scores less than 7 are mild, 8 to 18 is moderate, and greater than 19 is severe. There's also a quality of life score of 0 to 6, where 0 is delighted and 6 is terrible. I don't know how you can be delighted with your urinary symptoms. However, after treatment, many people are. And then finally, obtain a urinalysis. You want to assess for other causes of urinary tract symptoms like a urinary tract infection or blood in the urine, which may suggest a bladder tumor. So it's important to get that. Statement 2 is a clinical principle. Consider assessment of prostate size and shape via abdominal ultrasound, transrectal ultrasound, cystoscopy, or cross-sectional imaging. And this imaging should be obtained in the 12 months preceding surgery. So my thoughts on pre-op imaging, I see it's getting used more and more than it used to, and this is a good thing. So who do I think should get it? I think everyone should get it. Why do I think everyone should get it? The size of the prostate helps dictate the best procedure. So if you have a 200-gram prostate, an enucleation is probably going to be better than a resection or a vaporization procedure or mist. The anatomical configuration helps dictate the best procedure. So for example, a large middle lobe may preclude good results from a urolift. And so what imaging do you get? You can get a transrectal ultrasound, CT, MRI. I think the first important thing is to review the record. Lots and lots and lots of these patients have already had CT urograms for hematuria. They've had prior prostate biopsies or MRIs for other reasons. So no need to go getting extra imaging if they already have it available. As far as cystoscopy goes for sizing of the prostate, I personally do not find that I can adequately size a prostate by cystoscopy. I can tell that it's quite big versus quite small, but if I were to try to tell you that a prostate's 80 grams versus 150 grams on cystoscopy, I probably couldn't do that. So my thoughts on cystoscopy, who should get cystoscopy prior to a BPH procedure? So obviously anyone with gross hematuria or microscopic hematuria. Patients with prior surgery, I always do a cysto before taking them to the operating room. You want to evaluate for stricture as the cause of their symptoms, also sphincteric abnormalities. Unfortunately, some patients you will go in and find they've got a white-looking stented open sphincter, and that's probably from prior damage from prior surgery. And unfortunately, if you do a thorough clean out for them afterwards, they may be at risk for incontinence if that sphincter is not functioning appropriately. I also get cystoscopies on patients who have predominant irritative symptoms, so mainly the urge and frequency, and this is to make sure I'm not missing a bladder tumor. And then finally, I'll also do it with recurrent UTIs, but seemingly low residuals. Again, I've diagnosed a few bladder tumors in patients with recurrent UTIs. And so I'll oftentimes do that in these patients, and also see if they have any bladder stones or something like that. Statement 3 is a clinical principle. Physicians should perform a PVR assessment prior to surgical intervention. Why? Very high residuals may indicate failure of a medical regimen, need for more aggressive management. It allows you to monitor progression if patients opt out of surgery. And it allows you to assess for risk for upper tract deterioration. So you're not going to want to monitor someone who's got residuals in the 800-900 range. Statement 4 is also a clinical principle. Physicians should consider uroflowmetry prior to surgical intervention for BPH. For your testing, remember threshold voided volume for adequate interpretation is 150 cc's, and patients shouldn't Valsalva to void. It's important to not look just at the flow, the Qmax, but also to look at the shape of the curve, and this helps you kind of determine what may be going on from a pathologic standpoint. So if you look at these curves, the first one we see here is a normal bell-shaped curve. This is what you see with typical voiding. The one below it is the prolonged curve. So you see a small peak, but then a very prolonged off drainage. And so these patients, they generate a little bit of pressure or they're actually generating a lot of pressure, but they generate a small peak and then it trails off. The next one you see here, we'll see an intermittent curve. We see this sometimes in patients with BPH whose bladders aren't functioning well. And then below that, you'll see the box curve, which you never really get any sort of peak. And this is commonly seen with urethral strictures. And then the curve above, you can see the final curve that I haven't delineated here. Oftentimes you'll see that with overactivity, but oftentimes you'll also see that after someone's treated for their BPH and is now widely patent. Statement 5, clinicians should consider pressure flow studies prior to surgical intervention for urinary tract symptoms attributed to BPH when diagnostic uncertainty exists. In my opinion, most patients can be treated without UDS, but there are some benefits. It's the only way to truly assess for detrusor function or lack thereof. It allows for assessment in patients with symptoms of overactivity and incontinence to determine if maybe a bladder outlet obstruction procedure may not be in their best interest. And I think it's useful, particularly when the results may change your management. So my thoughts on pre-op UDS, who should get it? The patient presenting with this kind of picture when you see them in the emergency room, their bladder is distended up to the xiphoid, they've got bilateral hydronephrosis, you put a catheter in, they drain thousands of cc's of urine, post-obstructive diuresis, and then they're completely catheter dependent. And these people, it allows you to assess their bladder function and likelihood of success. It helps you guide a discussion about potential need for catheterization regimen post-op. And I think most importantly for patients that are elderly, unhealthy, high risk, determine, if the risk of surgery is more than the benefit. I operate on plenty of people who have very poorly functioning bladders, but I think it's important to have a good discussion about what you think your outcomes may be. And again, determine if in these high risk patients, is the surgery really worth it? I also tend to get it in patients with underlying neurologic issues, so spinal cord injuries or surgeries, a prior cerebral vascular accident, Parkinson's, where we may see overactivity. I'll often get it in patients with failure of prior BPH surgeries or no significant improvement after their surgery. This is especially true if I do a cystoscopy and there does not seem to be any significant obstruction on their cysto or on uroflowmetry. And I think, you don't want to do a second operation for someone if you really don't think it's going to be any benefit. For example, if they just have, poor detrusor function. I also get it in patients with predominant frequency, urge, and leakage. This lets you get a look for an overactive bladder, whether they have a low capacity or poor compliance bladder, which may not be corrected with surgical intervention, and in some cases may even be worse. Statement 6, clinical principle surgery is recommended. This is pretty obvious for patients with renal insufficiency related to their obstruction, refractory urinary retention, recurrent urinary tract infections, recurrent bladder stones, recurrent hematuria, urinary tract symptoms refractory to medical management, or simply patients unwilling to tolerate or accept medical management. And then final clinical principle here is do not perform surgery solely for the presence of an asymptomatic diverticulum. but consider evaluation for obstruction in these patients. Indications for treatment of a diverticulum would be in patients who continue with poor emptying because of the diverticulum, recurrent infections because of the diverticulum, stone formation in the diverticulum, and things like that. So now we're getting into the actual surgical therapies. So statement 8, moderate recommendation, evidence level B. TURP should be offered as a treatment option for men with urinary tract symptoms attributable to BPH. No size threshold is recommended in the statement. However, I think most people would not be doing TURPs for prostates greater than the 80, 90 gram mark. Statement 9 indicates that monopolar or bipolar approaches can be used based on expertise. Safety profiles favor bipolar clearly. There's lower bleeding and blood transfusion rates. There's essentially no delusional hyponatremia or TUR syndrome with bipolar approaches, and you have increased safety with longer resection times with bipolar. So the general technique for TURP, well, a lot of people will be familiar with this for our younger residents. I always recommend pre-dilating the meatus and fossa navicularis. Most urethras are not ready to just accept a 26 or 28 French resectoscope sheath. So we typically do this with serial sounds, starting with 20 or 22 French and going up to 28 or 30. If the meatus and fossa is still particularly tight, I personally will use a Otis urethratome to open up the fossa. I think a straight shot cut is much less likely to cause a stricture than that rotating jamming motion that we try to do to get scopes in when it's too tight. It seems barbaric, but it actually works quite well, and we see very low stricture rates here, and that's what we use when we can't get in just off of sounds. As far as getting the sheath in, I would recommend using a visual obturator. It will never hurt you to use a visual obturator, although it's not completely necessary, but I think there's no reason not to. And you always want to evaluate your bladder and prostatic urethra to identify the relevant anatomy. Look for your ureteral orifices, look for your middle lobe component, assess where the vero and sphincter are located to prevent inadvertent injury to them. The general technique is an organized resection from the bladder neck to the vero. Most will start between the 5 and 7 o'clock position and take that down to capsule, which on the right side picture here, you can actually see the capsule up by the bladder neck fibers fairly well. You want to resect the lateral lobes down to the same level, and you want to avoid resection beyond the vero to preserve the sphincter. You want to carefully assess for hemostasis at the completion of the procedure. My residents who are on here know I'm crazy about this at the end. See what your blood pressures are before you complete the surgery. Anyone will have pretty good hemostasis if their systolic blood pressures are running in the 80s. But I really always try to get those blood pressures up to the 110s, 120s. You'd be surprised how many times you pick up some bleeding that you didn't know about. So always ask your anesthesiologist, get those blood pressures up before you complete the procedure so you know you're safe to stop. So these, I'm now trying to go through some of the prominent literature for BPH. BPH is kind of the Wild West when it comes to treatments and studies. So the 1989 study and the 2008 study, these kind of look at the immediate outcomes of TURPs, and these are the very, very large studies, which we don't have a lot of currently. So both looked at huge numbers of patients, and you can see 30-day mortality did significantly improve over 20 years with reduction about half. Post-op complications were improved. You can see transfusions improved, not tremendously, and TUR syndrome obviously going down because of the introduction of bipolar resection. Little bit improved tissue resection. Now, interestingly, you'll see a decline in prostate cancer detection, which I can't really explain that other than maybe better screening. I do see in my practice about a 10 to 15% incidental prostate cancer, at least in whole-up specimens. The first study didn't really look at results, patient-related results as far as Qmax and PVR, but the second study did show good improvement in flow rate and good improvement in PVR, and these numbers that you see here will be similar to what we see in multiple studies regarding TURP. But these are kind of when you see people refer to studies on the safety of TURP, these are kind of the landmark studies that they talk about. So this is from a review article, and it just kind of goes through multiple TURP trial or TURP studies and looks at their improvements in IPSS, quality of life, flow rate, PVR, PSA, and you can see here the top one is open prostatectomy. But if you look at all the TURP groups, you see a pretty, and these have pretty decent follow-up, 40 to 100 months. So you see pretty stable reductions in IPSS in all these groups, pretty similar. We typically quote about a 15-point IPSS drop with TURP. We see good improvement in the quality of life scores, good improvement in the flow rate scores, and or flow rates, and significant improvements in PVRs. PSAs show moderate declines, and if you look at data, not including just this data set, but if you look at the reoperation rate for regrowth adenoma at 5 years after TURP, it's anywhere from 3 to 12%. If you look at reoperation rates for strictures at 5 years, it's 2 to 4%. And you'll see as we go through the rest of this lecture that the studies will basically, for all these new procedures, will compare their results to TURP as the gold standard. But TURP has a good track record for good improvement in symptom score, quality of life, flow rate, PVR, and PSA, although not the best with regards to need for reoperation. Statement 10, consider open, lap, or robotic simple prostatectomy for patients with large prostates. Again, no size criteria is given in the guidelines, but it's typically considered for glands over 80 to 100 grams. Benefits of this is you can concomitantly treat a large diverticulum or bladder stones if needed. There's retropubic or transcapsular and transvesical approaches. But I will say in almost all instances, similar tissue removal and functional outcomes can be achieved with an endoscopic enucleation. So we do a few of these here for occasionally for people with strictures, prior stricture repairs. We don't do a whole lot of them here because we have the ability to do whole lip. But in general, if we were to do them here, they'd be done in a robotic fashion. Basically, the general technique is you're going to make a cystotomy. We used to drop the bladder, but we don't even do that anymore. We just go right in through the posterior wall, identify the radial orifices. You're going to make your mucosal incision and identify the surgical capsule, which is between the transition zone and the peripheral zone. You can then use stay sutures or tenaculum, which we now use a tenaculum, to retract the adenoma. And then you fully dissect the adenoma free from the surgical capsule, much like you would do with your finger bluntly during an open simple prostatectomy, but with much better bleeding control. Some people will divide the anterior commissure. Here we usually just take the gland out all in one piece. You can advance the bladder neck mucosa down to the urethra, and you close your cystotomy. You can leave or drain or not. You can do CBI if needed. Most studies indicate a catheter dwell time of 3 to 7 days, plus or minus a cystogram to follow. We typically do cystograms here. If you do a cystogram, look at it on your own. A lot of times you'll get a leak called because you have this massive prostate cavity and they'll think that's a leak. Or sometimes you'll get reflux into the seminal vesicles and they'll call that a leak, but that has this very serpentine, very obvious appearance. So always take a look at them on your own because it's probably very unlikely that you have a leak after an operation like this. So what's the data? So this is a very large multi-institution trial out of Europe. And they looked at 1,300 patients undergoing minimally invasive simple prostatectomies. They used lap and robotic approaches, transcapsular and transvesical approaches. And this just shows the predominance of, can you guys hear me okay? This just shows a predominance of robotic procedures as we get to 2009 through 2014. So if we look at these procedures, the 1,300 or so that were performed, the mean prostate sizes were about 100 grams. So these are not massively enlarged prostates. And the mean adenoma volumes were about 60 to 70 grams, which again are not massive. But these are the typical glands that would have been treated with open simple prostatectomy. And if we look at how they did in the operating room, so operating times about an hour and a half to 2 hours, a little bit longer than it would typically take for open simple prostatectomy. blood loss was very reasonable in these groups and equivalent amongst the groups. Length of stay, obviously is longer than you get with endoscopic procedures, but around 2 to 4 days, and catheterization for 4 to 7 days. We see excellent reduction in their PSAs down to the 1 level, which is what we're also going to see with endoscopic enucleations. And we see good improvements in Qmax and stable IPSS, or good improvements in IPSS scores and stable SHIM scores. So we see improvements equivalent to TURP with regards to functional outcomes and better PSA reduction in these groups. And if you look at this, the complications in these groups are very low. So very low rates of any type of complication. And if you look at bleeding and need for transfusion, I believe it's only 7 out of all the 1,300, which is a very low transfusion rate. And if you look at the literature for open simple prostatectomy, you'll see transfusion rates as high as 30% in some series. So it does improve the blood loss. Some of the downsides are a little bit of extra time and probably a little bit extra cost. So my thoughts on open simple prostatectomy, in the US, open simple prostatectomy is a dying procedure. It certainly can be done, but we have means to do it with endoscopic enucleations and laparoscopic and robotic procedures. These procedures allow for less blood loss and smaller incisions, and patients getting out of the hospital, at least here, usually post-op day 1. So I think open simple prostatectomy is on its way out. We looked at our numbers from 2013 to 2018 sometime back, and we did about 1,000 BPH procedures over that time, with a split of about 500 whole up, 500 TURP, TUVP, with about 10 robotic simple prostatectomies and 0 open simple prostatectomies. So it's probably a procedure that, yes, can still be done, but probably can be avoided in most. But I do think lap and robotic simple prostatectomy has a role. If you have lack of access to equipment or expertise for endoscopic enucleation, I think for patients who have a modest stricture, which you may make worse by dilating and putting a 26 French sheath across it, I think in patients who have had a prior urethral stricture repair, it's probably better. And then I think if you have a need for concomitant treatment of a big diverticulum, it's also beneficial. And then we'll talk about this later. For massive BPH, where a perineal urethrostomy may otherwise be required, this may be a better approach, or even in a combination approach. Statement 11, transurethral incision of the prostate should be offered as an option for patients with prostates less than 30 grams, so less than or equal to 30 grams. I would be good to consider it in appropriate patients wishing to attempt to preserve ejaculatory function. So the general technique that you'll see described is 5 and 7 o'clock incisions with the Collins knife. So for some of the younger residents, you may have never even seen a Collins knife. You basically start just distal to the ureteral orifices and carry the incisions proximal to the viru. At the level of the bladder neck, you really deepen to perivesical fat, which is a little bit of a scary sight, especially if you've done this, and if you see in the picture to your right, you deepen into the prostatic capsule within the prostate. There's variations to this technique with a 6 o'clock incision or 1 single incision at 5 or 7 o'clock with hopes to decrease retrograde ejaculation. There's different energy sources available. I've seen it done with monopolar, bipolar, or bipolar probe lasers, but in general, the goal is the same. For my small prostates, either for a small TURP or a small hole up, I'll oftentimes do an incision at the bladder neck like this to prevent bladder neck contractures. So this is a study that looked at 100 patients with prostates less than or equal to 30 grams, randomized to TURP versus TUIP with no middle lobe. And it's an older study, but if you look at the results, they showed very similar improvements in IPSS score, very similar improvements in quality of life, very similar improvements in flow rate improvement, and then a decrease retrograde ejaculation rate in the TUIP group. Although I'll say the 32% retrograde ejaculation rate for the TURP group is probably a little low. There were no transfusions in the TUIP group and only 2% in the TURP group. The pros of this is it's an easy procedure to perform. There's a very low transfusion risk with reports of 0.4 all the way up to 8.6. And there's decreased retrograde ejaculation if you look at multiple series, and that 65.4% retrograde ejaculation is more consistent with what we see with TURP. The cons are it's really only suitable for 30-gram or less glands, and then there's a higher reintervention rate for, and this is for prostates in the 30-gram size range, so 15.9% for the TUIP group versus 2.6% for the TURP in this subset of patients. Statement 12, bipolar transurethral vaporization of the prostate may be offered as a surgical treatment option. So I apologize, Dr. Mortinos had given me a beautiful video to put in here, but I just could not get it to work, so a picture will have to do. So there's multiple different probes that you can use. There's buttons, there's roller balls, but generally what happens is you're creating a thin layer of highly ionized particles that allows the probe to glide over the tissue. You, with the foot pedal, generate an initial electrical pulse that creates a constant plasma field, and this allows you to vaporize a thin layer of cells without deep penetration. It allows you to vaporize and coagulate simultaneously. And the advantage are, again, using saline irrigation. You get better coagulation and visualization, and potentially can do this while continuing anticoagulation or antiplatelet therapy. So this is an interesting study that came out not that long ago, 2019, and they looked at 75 patients undergoing pure bipolar TUVP. They followed them for 3 years and even did 3D ultrasound sizings of their prostates. Again, these are small prostates, and you'll see with a lot of these procedures we're talking about now, they're kind of limited to smaller prostates in the 40 to 50 gram range. About 34% of the patients were on aspirin when they did this. None were on Plavix or Coumadin. The operative times were a little bit long in this group. Typically, we see them more in the 30 to 50 minute range, but they were longer, and I think that has to do with actually a very thorough resection, as you'll see with the numbers as we come through the rest of this presentation. Blood transfusions were 0, catheters for 3 days. And so this is when they looked at their prostate volume reduction. So you can see over 3 years, they had a stable 50% reduction in prostate volume, which is pretty remarkable if you know how minimal of tissue you get with each swipe of that button. So I think that may explain why their operation times are a little bit longer, I think, for just really aggressive resections. But that stayed stable at 3 years, which is impressive. And then they look at their patient outcomes, and you'll see that their IPSS score is stable and low out to 3 years. Quality of life is improved out to 3 years. Qmax is, improved, not dramatically so, but definitely improved and stable at 3 years, and residual volumes are low and stable at 3 years as well. And they also have a good reduction in PSA. Again, these are smaller glands with not super high PSAs to start, but you would expect this drop in PSA with a 50% reduction in the tissue. They reported a 0% reoperation rate for regrowth at 3 years. However, fairly high reoperation rates for urethral strictures and bladder neck contractures, although we don't see this in other studies, and this may be related to the longer operative time. This is a very large study comparing bipolar TUVP to bipolar TURP and monopolar TURP. 510 patients prospectively followed for 18 months. Again, smaller prostates, under the 60 gram range on average, and PSAs in the 2 range. And if you look at these numbers, the perioperative features and complications, for the most part, do favor the bipolar vaporization group. There's less bleeding. The operating time in this group is lower, and there's shorter catheterization periods and shorter hospitalization stays. There's no TUR syndrome, nor is there with the bipolar TURP group. There's low rates of blood transfusion. And then if you look down at the bottom, the retreatment rates are more similar here than what we see in the TURP literature. So a retreatment rate the retreatment rate for regrowth is a little bit lower than we see with the TURP literature, but the bladder neck sclerosis and urethral strictures are more in line with what we typically see in the literature for TURP. And so they followed these patients out to 18 months, and you can see a sustained improvement in their IPSS scores, with it favoring, statistically significantly favoring the vaporization group. And the Qmax, although very similar, did statistically significantly favor the bipolar vaporization group. And statement 13, clinicians should consider PVP as an option using 120 watt or 180 watt platforms for the treatment of urinary tract symptoms attributable to BPH. So not the lower power systems, but the higher power systems. So what's the technology of green light? So it's developed by doubling the frequency of a pulsed ND-YAG laser with a KTP crystal. This allows for a visible green wavelength at 532 nanometers. This wavelength is selectively absorbed by hemoglobin, and you get rapid photothermal vaporization of heated intracellular water, which leads to photoselective vaporization. The penetration depth with this laser is deeper than you see with holmium. It's about 0.8 millimeters, and the coagulation zone is 1 to 2 millimeters. However, it does allow for decreased dysuria and sloughing that you would typically see with ND-YAG lasers. Typically use a side firing 600 micron fiber. You work in non-contact mode where you work very close to but not touching the tissue. There's a gazillion techniques for vaporization as are listed here, but the general goal is an organized vaporization down to surgical capsule. So the Goliath study you've probably heard of, it's a RCT comparing TURP, green light, using the 180 watt system, and they have 2-year data in this study. And so they did a non-inferiority study to start, and as you can see here, they demonstrated that there was non-inferiority of green light to TURP, at least for prostates that were under 100 grams. So if we look at these numbers here, again, we're looking at small prostates here. Their mean size is under 50 grams. If we look at the improvements at 24 months, we see similar improvements in prostate size reduction. We see similar improvements in PVR. We see similar improvements in PSA and similar improvements in quality of life. And if you look back at the first slide where we talked about non-inferiority, we can see that the IPSS score is similar and stable at 2 years as well. So they look at perioperative factors as well. Length of catheterization, about 40.8 hours compared to 60 hours for TURP. I'd say probably now people are having catheters even less than that for green light. Length of hospital stay, again, this is longer than we typically see here in the States. It would typically just be an overnight stay, but that also did favor green light. And then down the bottom, similar rates of tissue regrowth, bladder neck contracture, and strictures. And then they did show a slightly higher rate of new incontinence in patients undergoing green light, but when looking at moderate incontinence, there was no significant difference between the groups, and the vast majority of people resolved within 90 days. This is a summary of various studies looking at PVP for larger glands. So there's a couple in here that look at prostates about 104 grams. And you see here that there's a fairly good reduction in the IPSS, which we would see with TURPs, and similar to what we would see with open or lap simple prostatectomies. There's good and stable improvements in quality of life. There's good improvements and stable improvements in Qmax, and good improvements in PVR. What's interesting is that you don't see a dramatic decrease in PSA like you would typically see with enucleative procedures, which you have to keep in mind when thinking about potential for regrowth in the future, as there's clearly some adenomatous tissue remaining. This is a study from Kevin Zorn's group. This is looking at green light for very large glands, and including glands over 200 grams in size. If you look at it, you'll see that they're using quite a few fibers for this, which certainly adds to the expense using 3 fibers. And importantly, they show a 16% conversion to TURP for the 200 gram glands. I would hate to have to convert to a TURP for a 200 gram gland. If you look at the retreatment rate at under 18 months, you see that those numbers are getting up there. So we don't know what the retreatment rates are going to be at 2 or 3 years, but they're already fairly high at the 16-month mark. And you'll see declining reductions in PSA at 3 years. So you got to wonder how much tissue is actually being removed and whether this is going to be a long-lasting procedure for these people with extra large glands. Again, you also don't see a huge improvement in Qmax in the very large gland group. So I don't think that we're ready for prime time with vaporization for very large glands. I'm not sure it's going to stand the test of time for these patients, but time will tell. Statement 14, moderate recommendation, grade C. Clinician should consider prostatic urethral lift provided the prostate is less than 80 grams and there is absence of a middle lobe. Patient should be informed that symptom reduction and flow rate improvement is less than TURP and that retreatment rates are poorly defined at this time. And statement 15 indicates that it may be offered to eligible patients concerned with erectile or ejaculatory function. So the general UroLift technique is transurethral placement of transprostatic implants. They retract the lateral lobes and expand the lumen anteriorly. Use a 19-gauge needle with a monofilament and metallic tab that's deployed through the prostate. The tab engages in the capsule, and then the monofilament is tensioned and the urethral end piece is attached, and this is what holds the lobes apart. And the anterior channel is completed. The benefits are it's an office-based procedure, there's short operative time, there's low blood loss, decreased retrograde ejaculation, decreased incontinence, and typically rapid recovery. So we're all familiar with the LIFT study. So the first thing they did was a PUL versus sham, and they did this for prostates 30 to 77 lobes. They did a washout with alpha blocker and a washout with 5-alpha reductase inhibitors. The UroLift procedure was done as we showed on the previous slide. There was an average of 4.9 implants with a range of 2 to 11. The sham procedure was performed in the same room draping setup. A rigid cystoscopy was performed. The surgeon called for implant devices that were open but not deployed, and they used a biopsy device to simulate the UroLift sounds. The vast majority of the procedures were performed with oral diazepam and bladder and urethral lidocaine. The primary endpoint was an AUA symptom index reduction 25% greater for the UroLift compared to sham at 3 months. And so again, the mean prostate size here, just to show you, was 44 and 40 grams. So they did show that the AUA symptom index did improve from 22 to 11, so about a 50% reduction. And they did meet their endpoint that this was at least 25% better than the change in the sham group. They showed an improvement in Qmax, although it was small. It was statistically significant. We don't know how clinically significant. And then they showed no significant change in the ejaculatory dysfunction or the bother, and IIEF was similar as well. So then they looked at their results out through a year, and we see stable, sustained improvement in their symptom score. And just for comparison's sake, now that we're getting into the missed line, the medical therapy typically results in a 3.5 to 7.5 point AUA symptom index reduction at 1 year, and TURP is typically a 15-point AUA symptom reduction at 1 year. So this is in between that. The quality of life improvement was stable over time with the reduction of 2. And the Qmax, again, it's statistically significant, but only about 4 milliliters per second. So hard to know if that's clinically significant. And PVRs were not significant. About 77% of patients had a catheter post-op. The mean duration was about a day. Very low rate of adverse events. At 1 year, 5.6 patients required retreatment. 5 had a revision of the UroLift, and 2 had a TURP. 4% required initiation of medical therapy. They did cystoscopic follow-up at 1 year. There were no strictures. 4.2% of implants were noted to be exposed in the bladder. 2.1% had incrustation, and 1 required endoscopic removal. And then this is the 5-year follow-up from this same study. And again, it shows still a statistically significant improvement in IPSS, although that seems to decline over time, the degree of improvement. The quality of life stays stable. Again, the Qmax is statistically significant, but unclear if it's clinically significant. And then the ejaculatory function statistically is improved, and the bother score improved. So the retreatment rate at 5 years was 13.6%. 4.3% required additional implants, and 9.3% had a TUR or laser ablation. Approximately 10% or 11% of patients required resumption of medication at 5 years. And then as far as additional interventions, stricture dilation occurred in 1, and removal of implants protruding into the bladder occurred in 13. Statement 16, transurethral microwave therapy may be offered, and it should be known to the patient that surgical retreatment rates are higher. So what is TUMT? The products out there are Eurowave, Targus, Prostatron. I think we're doing these less frequently nowadays with the advent of the Eurolift and Resume. But generally the way it's performed is topical lidocaine and truss-guided lidocaine infiltration are performed. A balloon catheter with integrated microwave antennas positioned transurethral. There's a water cooling circuit that inflates the balloon and keeps the urethral temperature less than 45 to 50 degrees Celsius. There's a rectal probe placed which monitors the rectal temperature and keeps it less than 42.5 Celsius. The power is incrementally increased to its maximum over 1 hour, and this is different for different devices. If a urethral or rectal temperature exceeds the threshold, the system is interrupted for 2 minutes, and the goal is to achieve an intraprostatic temperature of at least 45 degrees Celsius, sometimes as high as 80 degrees Celsius, and coagulation necrosis occurs in the periurethral transition zone. So they've done some sham surgeries. This was one done with the Targus system. Again, these are small prostates. And they did show that there was a improvement that was greater in the microwave group as compared to the sham group with regards to AUA symptom score and with regards to Qmax. It was statistically significant, the difference between the two groups, although modest if compared to TURP, the improvement. And interestingly, they also looked at prostate volume and showed only a mean reduction in prostate volume at 6 months of about 7.6%. Complications were few. Retreatment rate at 6 months was 1.6%. And then we have a long-term study of Prostatron, which is a different TUMT device, versus TURP at 3 years. Again, these are procedures being performed for small glands. The prostate sizes are under 50 grams. And they looked at their results at 3 years. You can see that there was improvements in IPSS and quality of life and Qmax. They were statistically significant in both groups, but statistically significantly favored TURP in all instances. The TUMT group had a 19.8% failure rate, and that was or reoperation rate, and that was mainly because the therapy failed. TURP in this group had a higher than typically seen 12.9% reintervention rate, and that was typically for complications such as a bladder neck or a stricture. Statement 17, water vapor thermal therapy may be offered. This is our Resume that we're going to talk about. Prostate volume should be less than 80 grams, and patients should be counseled regarding the efficacy or retreatment rates. And statement 18 goes along with this. Water vapor thermal therapy may be offered in those who desire preservation of erectile and ejaculatory function. So what's the technology? It's convective water vapor energy, or WAVE. Radio frequency generates a wet thermal energy in the form of water vapor. You get transurethral thermal energy transfer. So you get release of a large amount of thermal energy as water vapor contacts the tissue and then condenses back to water. The vapor disperses rapidly through tissue when injected just above the interstitial pressure of the prostate. It disrupts the cell membranes and causes cell death and necrosis. It targets the transition zone. The steam will travel until it encounters natural collagen barriers. It cannot cross the true prostatic capsule, and no thermal effects outside of the targeted treatment zone are seen. The way it's done is a single-use vapor delivery device with a 30-degree cysto lens. A PEEK needle is deployed under direct vision into the prostate. Vapor at 103 degrees Celsius is delivered through 12 emitter holes, allowing for circumferential dispersion of the steam or the vapor. The average injection time is 9 seconds, and you typically start 1 centimeter from the bladder neck at the 3 and 9 o'clock position, and you make your injections 0.5 to 1 centimeter intervals down the prostatic urethra to the proximal viral. If there's a median lobe, you can do 1 to 3 injections. This is a nice video that the folks from Boston Scientific sent me to use for this talk. This used to be NextThera who owned it, but they own it now. And so basically you're seeing the cartoon on the left and the actual pictures on the right. And you'll see here, we don't have to show the whole video, but just to show what one injection looks like. and you'll see what in theory is happening in the prostate on the cartoon side here. So here you're going to see the needle come out. They're injecting the steam. It's about the vapor, it's about a 9-second injection. And then they'll come down towards the prostate and do additional, down towards the vero and do additional injections. So they looked at, this is a group that looked at what happens actually in the prostate after the resume therapy. And they looked at changes in prostate volume as well as defects seen on MRI. So at 6 months, they noted a mean change in 17.7 cubic centimeters, which was overall reduction in prostate size of about 29%. When looking at the transition zone, they noted a 13.8 cubic centimeter reduction in size, which was about a 38% reduction in the transition zone. And then they also looked at gadolinium defect lesions on MRI. And they noticed that over time, these MRI lesions disappear with a 95% reduction in the lesion over time. So this is just what their pictures look like. And so if you look at it, the orange is the transition zone, the green is right lateral lobe lesion from the resume, the blue is the left lateral lobe lesion from resume, and the pink is the median lobe lesion from resume. And what you can see is over time is that those at 1 week, 1 month, and 3 months nearly resolve, and then you have your reduction in prostate size. So this is one of the first studies with resume, comparing it to sham. They put 197 patients in and randomized 2-to-1 resume to sham, and there was medical therapy washout beforehand. The primary endpoint was a reduction in IPSS in the resume group of greater than 125% of the control group. And the prostate volumes here were small, and the PSAs were low. And I'm going to speed up now because I'm going to go way over time. 90% were catheterized for a mean of 3.4 days. There was an average of 4.5 injections. 69% had oral sedation, 21% had a prostate block, and 10% had IV conscious sedation. And so we see that they did meet their endpoints. They had about a 50% reduction in IPSS, which was statistically improved from the control group. And then they had no they did not have a lot of adverse events. They had 1 prolonged retention and 1 admission with nausea and vomiting. They had no changes in erectile function reported. They followed their data out to 12 months. They had a stable reduction in IPSS. Again, a marginal improvement in Qmax, which was statistically significant at about 5 milliliters per second. PVR was unchanged, and quality of life was stable and reduced out to about 2. They then followed it out for 4 years. And again, the IPSS stays stable with about a 46.7% reduction. The quality of life stable at about a 50% reduction. Qmax, while statistically significant, is marginal at about 4.2 milliliters per second at 4 years. The retreatment rate at 4 years was 4.4%. Alpha block initiation at 4 years was 5.2%. No real significant changes in PSA over 4 years. The IIEF and ejaculatory function were unchanged over 2 years, and the ejaculatory bother score was actually improved at 3 years. Statement 19, transurethral nasal ablation of the prostate is not recommended. Enough said. Statement 20, consider holmium or thumium laser enucleation of the prostate as a size-independent option for the treatment of urinary tract symptoms attributed to BPH. So HOYAG technology is a pulsed solid-state laser, generates a 2,140 nanometer wavelength. It's rapidly absorbed by water. The depth of penetration is 0.4 millimeters. It's well absorbed by prostate as there is a high water content. It allows for ablation and nucleation without deep tissue penetration. You can use saline irrigation. You get superficial penetration and thermal diffusion depth, which allows for concentration of high density energy in the superficial layers and seals the vessel, and you get a shallow coagulation zone. I put this picture up on the, this video up on the left just to show the beautiful planes you can establish with enucleation procedures. You see to the right is the adenoma, and to the left is the capsule. You see the shiny white capsule with the fine vessels. I'd love to say all procedures proceed like this, but this is a really nice example of what you're seeing, and a nearly bloodless field sometimes. You can do concomitant bladder and ureteral stone procedures as well. So how do we do it? There's 1,001 variations, and I'm just going to talk about HOLIP, but we know that there's thulium, there's diode lasers, people are doing green light enucleations, but this is the most studied as far as enucleation goes. Here we do it with the single posterior incision down to capsule. I usually start at the 5 or 7 o'clock position, and I'll enucleate the middle lobe with one of the lateral lobes. An apical incision. And we then continue with an apical and lateral dissection until we get up to the anterior portion at the 12 o'clock position, and we carry it over the midline, and we dissect all the way down till we see bladder neck fibers, and that's what you're seeing in this video here. So we're pushing the adenoma down, and we're trying to identify the bladder neck fibers. And you'll see as we're doing this, we get good hemostasis as we encounter blood vessels. And you'll see that as we're starting to identify the bladder neck fibers here, and we'll be able to enter into the bladder neck shortly. After that, we divide the anterior commissure. We encircle the lobe to identify the remaining mucosal strip, which is just a small strip that's attaching the adenoma to the sphincter. We divide that, and then we complete the dissection. You have to morcellate when this is all over. I used to suffer through using the old VersaCut morcellator, but now we have the Piranha, and this has made my life so much easier. So if you're going to do this operation, definitely get the Piranha. And then make sure you use dual inflow irrigation when you do this. I know not everybody does, but it prevents you from sucking in the bladder and potentially causing injury to the bladder. So this is one of the common papers you'll see. It's 3-year outcomes of HOLIP versus TURP. 200 patients were randomized, 100 HOLIPs and 100 TURPs. Prostates were less than 100 grams. Operative times favored TURP, but they had to use mechanical morcellation with a TURP loop because they did not have a morcellator. Post-op catheterization and hospital stay favored the holmium group. There were no transfusions in the holmium group. If you look at their 3-year results, TURP and HOLIP were comparable for IPSS improvement, Qmax improvement, and PVR. Similar rates of reintervention for strictures and bladder neck contractures. Retrograde ejaculation at 1 year was in the 70% range for both. Persistent urge incontinence at 1 year was similar for both. And new stress urinary incontinence at 1 year was similar for both. So now the big thing, let's compare HOLIP to open simple prostatectomy, because that's what we tout it as, so as being an alternative to. So this looked at 60 patients undergoing HOLIP versus OSP. The prostates were 100 to 230 grams with a mean size of about 113. You can see here that tissue retrieval was equivalent. Operating time, again, favored the open prostatectomy group, but again, they were using a TUR loop to morcellate the tissue. With the newer generation morcellators, we can now get upwards of 10 to 12 grams per minute morcellation time, so that really does improve the timing in the OR. Post-op catheterization and a hospital stay obviously heavily favored the holmium group. And again, you look at their data out to 5 years, it showed persistent similar results as far as AUA symptom scores go, persistent stable improvements in flow rate, and persistent stable improvements in residual volume. Again, similar rates of reintervention for stricture or BNC, similar rates of retrograde ejaculation, and a little bit of higher rates of stress urinary incontinence and HOLIP at 1 year. And then this is just a study that's probably one of the largest look at patients undergoing HOLIP, the largest number of patients. And they looked at patients according to short-term, intermediate-term, long-term, and greater than 5-year evaluation. And I didn't go through all their symptom score improvements because it's all similar to what you've already seen. But the reoperation for regrowth in this population was 0.1%. We also saw stable PSA reductions at greater than 5 years to about 0.95. With HOLIP, you'll typically see reductions in the 70 to 90% range when it comes to PSA. And here we're working with that premise as we start to monitor patients with active surveillance-worthy prostate cancer who also have BPH. We've been treating them with HOLIP, and PSA now becomes a reliable trigger for biopsies and MRIs and evidence of progression. We're also doing some unique things here with HoLEP. I don't know if anyone's ever tackled a 300 or 400, 500 gram gland endoscopically. It's quite challenging. It's very challenging to do from an open standpoint. It's very challenging to do from a robotic or lap standpoint. From a endoscopic standpoint, the bladder neck is very difficult. You can often have to do a perineal urethrostomy for prostates this big. From a robotic or open standpoint, the apical dissection is extraordinarily difficult. So we've here tried to come up with a way to see if we can improve the way we do this. And so basically we have, on very select patients, been doing a combined robotic simple prostatectomy with HoLEP. We've been doing it for massive BPH, so greater than 350 grams. We start with the HoLEP for the apical dissection. We carry the dissection as far up to the bladder neck as possible. We then dock the robot to do a cystotomy and complete the enucleation. You can treat any additional pathology like a diverticulectomy. We extract the adenoma via the port site, and there's no morcellation, which makes me very, very happy. And this is new to us. Our operative times are starting to improve dramatically with this as we adjust our techniques. Certainly these prostates this big are few and far between, so we haven't done a huge amount of them. But here you can see this is a 450 gram gland that we did from this approach. That's Dr. Keynes holding the specimen that I think eventually weighed out as about 330 grams. And you can see how well defined that adenoma is, and the apical dissection is well defined. And if you look at the virtual AUA, a shout out to Dr. Levy, who presented our series of 3 patients with a mean prostate size of 500 grams and our approach to this. Statement 21, and I'll be done in about 5 minutes, I promise. Aquablation may be offered to patients with lower urinary tract symptoms attributable to BPH. It's recommended for prostates 30 to 80 grams. Long-term evidence on efficacy obviously remains limited. So it's the AquaBeam system from Procept Biorobotics. It's a high-velocity, heat-free water jet for ablation of prostate tissue. Ultrasound is used for contouring of the prostate with sparing of the sphincter and ejaculatory ducts. The robotic system calculates flow rate based on length, depth, and width of resection required. Real-time monitoring of resection with cystoscopy and transrectal ultrasound is performed. Hemostasis is done with spot cautery or catheter balloon, and the resection times are about 4 minutes per pass. So this is a nice video that the Procept folks sent me, and I'm just going to fast forward it to the meat and potatoes of this here. So here you see they're starting to contour the prostate, and we'll take it from here. So now what they're going to do is they're going to measure the prostate and it's lengthwise, and they're going to identify the bladder neck, the mid-prostate, the viru, or their treatment end, and then they're going to contour it so that they pick the exact treatment route that they want for the water jet. And this is obviously sped up. It doesn't typically go quite this quickly. And you'll see that's the water jet coming through. The treatment time for the first pass is typically about 4 minutes. And you can actually, you don't really see much when you're doing the cystoscopic evaluation because you just basically see red and a little bit of craziness. Here they're going to do a second pass for additional treatment. And again, that's another 4-minute pass, which they have sped up here. And at the end, this is what it looks like. You see a lot of this fluffy stuff, which eventually sloughs off, and some oozing that you cauterize. So the first study is the WATER 1 study. So the water ablation therapy for endoscopic resection of prostate tissue is a non-inferiority study, men 45 to 80 with 30 to 80 gram prostates. They were randomized 2-to-1 aquablation, and the primary efficacy endpoint was a difference in IPS score change of greater than -4.7 at 6 months, and a primary safety endpoint was looking at the % of patients with adverse events Clavian grade 2 or higher, or any grade 1 event with persistent disability. So just to briefly go through, they met their endpoint, and you can see here the changes in IPSS, quality of life, improvements in Qmax, and post-void residual were similar and actually favored aquablation. Safety outcomes actually favored aquablation as well. And you can see the retrograde ejaculation, which is one of the things they tout with this because you preserve the viru and the ejaculatory ducts is 10% in aquablation and 36% in TURP. And you see that the changes in ejaculatory function favored the aquablation group. They looked at their results over 3 years and showed similar steady improvements in IPSS, quality of life, flow rate, and PVR. Ejaculatory function obviously again favored aquablation. Medical failure, meaning need to initiate alpha blocker or 5-alpha reductase inhibitors, was 9% in aquablation and 14% in TURP. The retreatment rate at 3 years was 4.3% for aquablation and 1.5% for TURP. The WATER 2 study looks at 80 to 150 gram prostates, and they looked at 101 men undergoing aquablation for 80 to 150 grams. And this is important in this group. They opted not to do any spot cautery at the completion of procedures, and a catheter tensioning device was used instead. So these prostates mean were about 107 grams. Catheters stayed in for about 94 hours, and hospitalization was about 1.6 days. 29% Clavien greater than or equal to 2 at 1 month. The interesting thing here is a fairly high transfusion rate. So at the index procedure, there was about a 6% transfusion rate. Delayed transfusion rate was about 4%. They needed to take 3% for cystoinfiltration at the index procedure and delayed. And I think this has a lot to do with not doing spot cautery at the end of the procedure and instead using a tractioning device. So at 1 year, we see a mean IPSS reduction of 17, a mean quality of life reduction of 3, and a mean Qmax increase of 12 milliliters per second. No change in shim, an improvement in ejaculatory dysfunction. The ejaculatory dysfunction was not significantly changed over time, I should say, or the MSHQ, ejaculatory dysfunction score, was not significantly changed over time, and only 19% had retrograde ejaculation. Incontinence requiring pads at 1 month was 8%, 4% at 12 months. We see slightly similar numbers for HOLEP, but with improved incontinence rates at 12 months. Reoperation rate was 0%. PSA reduction was about 38%. So to be determined what aquablation has to hold. We look forward to doing a bit more work with that to see how we can do. Statement 22, prostate embolization is not recommended outside the context of a clinical trial. It's beyond the scope of today's talk. The data is very heterogeneous, and the study designs aren't great, but there are ongoing studies now. We've had some personal anecdotal success with recurrent prostatic bleeding, and that's all I've really used it in currently. And then finally, and I'll be done in 2 minutes, statement 23, HOLEP, THULEP, and PVP should be considered in patients at higher risk of bleeding. Several studies have evaluated the safety in patients on aspirin and Coumadin. Similarly to slightly higher rates of transfusions are noted in the anti-coag groups. There's longer lengths of stay and hospitalization for the anti-coag groups. There's very limited data in patients on direct oral anticoagulants such as Xarelto and Eliquis. So in conclusion, many surgical options are available for the management, as you can see from this presentation. Prostate imaging is important in guiding the selection of the appropriate procedure. Missed procedures are attractive options in appropriate patients wishing to preserve erectile function. There's less robust improvements in AUA symptom score and Qmax, and the long-term reoperation rates are to be determined. Enucleation procedures are superior for very large glands. Concomitant procedures such as bladder stones and diverticuli treatment can be performed, and you avoid multiple reoperations. I think in these patients, the first procedure is their best shot as having the best outcome. Aquablation is promising for at least for the 30 to 80 gram glands, and time will tell. PAE should be in the setting of a clinical trial, but may be considered for refractory prostate bleeding and poor operative candidates. Laser treatments are best for patients on antiplatelets and anticoagulants, but I would say don't try to be a hero. Aspirin is typically not an issue. Talk to cardiology. It's amazing how many patients are still on Plavix with no indication, patients who are still on Coumadin for a clot that was related to an orthopedic surgery 5 years ago. Lots of patients have low CHAD scores and can come off of their anticoagulant therapy. Having done HOLEPs on aspirin, on Plavix, on Xarelto, on Coumadin, it's not fun. If you have had a catheter forever and recurrent infections, it's even less fun. So if you can get your patients off it, I would advise that you do. And only the other thing is to consider is if someone truly can't come off their anticoagulation and then you get into trouble, you have to think about how you're going to manage that afterwards when you have to stop their anticoagulation. So that's all I've got. Sorry for the going over. These are the references.